5, 4, 3, 2, 1. Sir, we are live now.
Thank you so much. Good morning, everyone. Sorry for the slight delay due to technical issues. So today in fellow teaching module for Orthokids clinic, we are start discussing for next 2 months the day-to-day pediatric orthopedic cases which we encountered in our daily pediatric orthopedic OPD. So for the first lecture, we have Dr. Deepak Khurana, who did his MS Ortho from SMS Medical College and then trained himself in pediatric orthopedics at two of the prime institute in India, like Bombay Institute under the guidance of Dr. Atul Bhaskar and with Dr. Ashok in Children Orthopedic Center. Sir will give a talk on Genu Valgum, when to watch and when to intervene. Over to you, sir. Thank you.
Am I audible?
Yes, sir. Yes.
Let me share the screen. Everything is visible now?
Yes, sir.
So, start now. So, Genu valgum, they generally present very commonly to an orthopedic and pediatric clinic. Many a times they are physiological or a true deformity. So, it's very important to differentiate that whether it is a physiological angulation or whether it's a true angulation. True angulation may result from many pathologies of epiphysis, physis, or metaphysis, or it can be a malunited fracture as well. If untreated, it predisposed to wear and tear of the joint instability, and eventually lead to premature.
So you are not audible, sir.
Hello.
Yes, sir. Now you are audible.
So with growth, they gradually straighten to a zero tibiofemoral angle around.
So your voice is getting blocked, sir.
Hello. Am I audible now?
Yes, sir. Yes, sir.
Okay. With further development, a physiological valgum develops, which goes around to a maximum angle at around 3 to 4 years. A normal adult values of physiological Genu valgum develops.
Dr. Deepak, we are not able to hear you.
I think sir is disconnected, sir.
Oh,
ये चालू है सर का.
हाँ तो है. मैसेज करना पड़ेगा. डॉक्टर दीपक.
अभी आ रहा है क्या?
हाँ अभी आ रहा है.
Now it's good, sir.
What happened? No, Bluetooth was disconnecting.
Okay.
So it can be caused. What are the causes? Causes can be physiological, idiopathic. It can be because of epiphyseal issues like skeletal dysplasia or syndromic. Either it can be physis like post-trauma, post-infection, or in case of sick physis like Olius disease. It can be metaphyseal cause like metabolic, and still there can be a metaphyseal skeletal dysplasia. So this is a typical case of a physiological valgus. You can see at an early age there was a significant valgus which can be clearly seen on X-ray, and it typically remodels with time. It can be a 7-year-old female with exaggerated idiopathic valgus. There is no any cause behind it, but still they are having that valgus. It can be a metabolic deficiency, vitamin D deficiency related valgus. It can be a resistant ricket like in hypophosphatemic rickets. You can see the severity of the valgus they develop with time. It can be an epiphyseal dysplasia. It can be a metaphyseal dysplasia related valgus. It can be an achondroplasia related Genu valgum. In those cases in which we are finding an asymmetrical presentation, so we have to rule out certain other pathologies like physeal bar because of post-trauma. It can be because of sick physis like Oleus disease. It can be because of post-osteomyelitis Genu Valgum. So these asymmetrical cases are very important for evaluation. So evaluation. Patient after the age of 7 years with persistent valgus and intermalleolar distance of more than 10 centimeter needs evaluation. All unilateral and asymmetrical cases at any age need evaluation. Cases with positive family history of skeletal dysplasia, short stature, and post-traumatic and post-infective deformities, they all need evaluation irrespective of the age. What investigations need to be done? It can be, first of all, we have to get a hip to ankle X-ray standing, an elbow lateral view, and hand X-ray, and a metabolic profile. So how to get an hip to ankle X-ray? So it's important to get it in a standing position, patella facing forward and pelvis squared. Don't try to squeeze both the legs in a single film, because doing so, we will tends to external rotate the limbs. And because of that external rotation, it will can underestimate the magnitude of the deformity. You can see on this X-ray on the right, this kid has a bilateral symmetrical valgus, but because the right limb has been slightly internal rotated, so you can see the mechanical axis appears to be passing through zone 1, which seems like there is no deformity. But similarly, on the left side, you can see there is a significant valgus. The mechanical axis is passing through zone 2, zone 3. So it is important to which is important to identify the level of the deformity. So to identifying level of the deformity, we do malalignment test through which all these angles and subluxation and condylar asymmetry is identified and calculated. So why it is necessary to identify the accurate level? So that we correct the deformity at the accurate level. What will happen if we will not correct the deformity at accurate level? It can lead to joint line obliquity, lateral medial thrust, joint instability, and early damage. So we can understand that particular concept with this example. This kid having a metabolic related Genu Valgum, which was corrected first through a metabolic profile correction and then planned for further deformity correction. So he is having an asymmetrical valgus more on the right side and less on the left side. So by applying a malalignment test to this kid, we can see on the right side, mechanical LDFA is 77 and MPTA is 101. So both tibia and femur are contributing to its deformity. But on the left side, only femur is contributing. And you can see the joint lines are oblique. So if in this case, the total correction, if we plan a correction only on the femoral side, what will happen? So after correction, this is the position. Yes, we have an aligned mechanical axis, but you can see there is a oblique joint line, which is not good for any joint. Similarly, if we plan the correction on the tibial side only, so this will be the final correction picture. And yes, we have an aligned mechanical axis, but still the joint line is oblique. So the basic thing is we should correct the deformity only at the level where it is. It's not like that, like a femoral deformity can be corrected on the tibial side or a tibial deformity can be corrected on a femoral side. So there is a very good paper in the journal The Knee in which they have discussed the obliquity, what joint line obliquity can cause to a tibiofemoral subluxation that alters the contact area and meniscal loading. So the conclusion was a 4-degree change in joint line orientation in either valgus and varus can cause significant subluxation in tibiofemoral area. So in this case, on the right side, both tibia and femur were done, and on the left side, only femur was done to get the full correction. So when to wait and when to intervene. So there are 5 factors on the basis of which I generally decide when to wait and when to intervene. First is age at presentation. Second is the gender. Third, what is the actual cause of the deformity? What is the zone of mechanical axis deviation and whether it is a symmetrical or a unilateral case. So age. So this is a clear-cut case in which an 18-month-old female came to the OPD for this valgus. So it is clear-cut, like we'll observe this child. Yes, we get a baseline X-ray because having this much of valgus at 18 months, it's a bit early, but yes, you can get it. To the contrary, on this similar type of valgus in a 10-year-old female, definitely we will plan for intervention like growth modulation. But the confusion comes when a 7-year-old female presents with this valgus. So it is on X-ray and metabolic profile, everything was done. It was idiopathic or an exaggerated physiological valgus. So whether to intervene at this age or not, it's controversial. So there is a concept of rebound deformity after growth modulation with coronal plane angular deformity about and who gets it and how much. So in nutshell, the conclusion of this article was younger age at growth modulation significantly increase the risk for rebound deformity. It has no implications of any gender of the child, direction of the initial deformity, severity of the deformity, duration of the follow-up, amount of overcorrection. Nothing was correlated, but only the significant factor was younger age. So while doing growth modulation at this early age, we should have that thing in caution. They might go into rebound phenomena and may need another episode of growth modulation in future to correct the deformity. So the timing of epiphysiodesis, most reliably, as literature say, you can calculate at what time you should do growth modulation depending on the bone which is involved, the desired correction which is needed. We can put all the data into this app and it can tell. But in practical purpose, what I do in my practice is we get an elbow X-ray, and on the basis of that elbow X-ray, we decide what sort of correction is needed and what sort of method should be used. So if you can see in first 1, 2, 3, 4 pictures, yes, we can say you can get a decent correction with all these elbows, with all these skeletal age. But after 5, 6, 7, you can say the correction, you can get some correction, but it shouldn't be that optimal to get a full correction, and they may need an osteotomy later on. And on the last 2, I tend to avoid doing growth modulation at this age because they tend to don't correct slight only. So ultimately they will land up into an osteotomy. So if we compare the velocity chart related to age, especially in girls, we can see there is a point at which they are getting their menarche. So it is a point, it is beyond their peak height velocity. So asking for menarche is a very important question, especially in case of girls. You can see after having that menarche, the velocity this drastically decreases. So getting a correction beyond 6 months of that menarche is nearly impossible, and I tend to wait further and get an osteotomy for them, advise them for an osteotomy. But similarly in boys, it can extend up to the age of 40. We can understand this with this case, a 12-year-old girl with a Genu Valgum, post-menarche she was 6 months, and elbow X-ray is showing almost fuse. So many, there is a controversy related to this. You can say, yes, physeal scars are visible and everything is there, but those physeal scars can be exaggerated because of vitamin D deficiency. That zone appears to be widened and it appears to be a widened physis, but actually it is not. So in this case, what my option remains is I better tends to wait and do a corrective osteotomy later on. One concept which is there in the literature, if you want to get the correction in these cases, pets is a better option because the lag period is very less in pets. So a similar case with a 14-year-old boy who presented with this wide open physis. So growth modulation is an easy option to pick in this case. Now comes the second factor, cause, metabolic. Always correct a metabolic profile first. Once radiological healing has started, then do the growth modulation. Wait for complete healing if planning a corrective osteotomy. If growth remaining is less, then a single shot of 6 lakh of vitamin D, and then the procedure can be done. Like this, a vitamin D related Genu Valgum, metabolic profile was corrected first, and then the patient was planned for Genu Valgum, growth modulation. Skeletal dysplasia. In all sort of skeletal dysplasia, when the family history is suggestive of skeletal dysplasia, there's a patient having short stature and severe deformity, always get hip X-rays. Since these patients have less growth potential compared to their peers at that age, it is best to intervene as soon as possible, especially when we are diagnosing Genu Valgum with skeletal dysplasia. Since joint lines are not that clear, so it is better to do an intra-op arthrogram to decide for the level of the deformity. Like in this case, a 6-year-old boy presented with epiphyseal dysplasia related Genu Valgum, and I planned for growth modulation correction as soon as possible. So you can see on the knee X-ray, it appears to be like both tibia and femur are involved. So in this case, whether we have to do both tibia and femur or only femur or only tibia, I tend to do an intra-op arthrogram. So like in this case, you can see the intra-op arthrogram is showing that the deformity is mostly on femoral side. Tibial side condyles, they appears to be normal. So I opted only for femoral side correction. And this is a 2-year follow-up. Still the child is correcting. See how slow they grow. And because of that slow growth, it's advisable to do growth modulation, especially when we are dealing with skeletal dysplasia at an early age. Because if you leave them, the deformity will progress, and it will progress to a certain extent. Like even after growth modulation, will not get the full correction, and you are not it's not advisable to get a full correction acutely at skeletal maturity of this much decrease. So you can see this was the intra picture, and this is the current picture of that. See the divergence of both the screws, and these screws are diverged without backing out, which was a disadvantage with the staples which was used initially. And this divergence happens because of the special design of the plate and the screw head. It tends to toggle around 30 degrees. It can toggle in that head of that plate, and these 30 degrees is the limit at which it can allow the correction as well. Because if it go beyond that, it tends to back out and can cause permanent epiphysiodesis also. So there is a paper in which they have discussed the radiographic assessment of guided growth in post-operative period and the correlation of the screw divergence with the change in anatomic angle. So they say for every 1 degree change in screw divergence, there is 1.8 degree change in femorotibial axis, and for every 2.11 degree change in LDFA, the correlation between change in screw divergence and change in anatomic alignment is irrespective of the height, weight, sex, and age of the patient. So post-operatively, focal radiographic imaging of the knee can be utilized, and those standing full-length X-rays can be avoided to avoid any to limit the radiation exposure to the patients. Third factor is zone of mechanical axis deviation. So the knee joint is being divided into 4 quadrants. The central 2 are zone 1, and the outer 2 are zone 2, and beyond that is zone 3. So whenever a mechanical axis is passing through zone 1, I tend to observe them. If it's passing through zone 2, then I tend to plan growth modulation at a proper age, which is more than 10 in girls and more than 12 in boys. And whenever I see a patient, the mechanical axis going through zone 3 and beyond, so I tend to advise them, yes, he will need or he or she will need the surgery. It's your choice whether you want to get it done now or later. Because why to keep that child with that deformity for next 2, 3, or 4 years when you know that it will not remodel with time? Having that thing in mind, yes, there is a phenomena called as rebound phenomena, but it's not true in all the cases. Then comes all the skeletally mature patient in which osteotomy is an option, PHYSIS is fused. So I tend to plan osteotomy in zone 2 and beyond, not in zone 1. So options are medial closed wedge osteotomy, lateral open wedge osteotomy, or a focal weeping dome osteotomy. So caution while doing the osteotomy. Since the cora in these deformity is at the joint level, the osteotomy is done away from the cora. So to avoid a secondary translation deformity, the distal fragment must be lateralized. As you can see in this case, the surgeon has done a closed wedge osteotomy, but it is not taken care of the translation. So now the anatomical axis of femur of proximal and distal fragment is totally malaligned, and they have created a secondary translational deformity. So to avoid those things, there is an option of oblique medial closed wedge osteotomy or a focal weeping dome osteotomy, like in this case. So unilateral and post-trauma, post-infection cases, since they are progressive in nature, like skeletal dysplasia, if they present early, bar excision and growth modulation is an option. So it can either prevent the progression or it will definitely correct the deformity to a certain extent. If they present late, then complete epiphysiodesis to prevent further progression of the deformity and later on correction through corrective osteotomy and lengthening. So this is a case example. This is a 6-year-old boy presenting with progressive Genu Valgum post-trauma. So on examination, on radiographic examination, you can see there's a physeal bar on the lateral distal femur and the mechanical axis is passing through zone 3. And on CT, it shows a linear bar on CT scan, which was resectable. So what was the plan? Plan was to excise that bar and do a growth modulation for the medial side. So the bar was exposed through the anterolateral incision by knee arthrotomy, since it was going through anterior and posterior. So the bar excision was done. It was interposed with a fat graft taken locally. This is the inter-op pictures. So this is at follow-up. So after 2-3 months, 4 months, it came to zone 2, then to zone 1, and this was totally central. And this is his latest follow-up. This is one more example. A 15-year-old boy presented with a proximal tibia progressive Genu Valgum post-infection. So the debridement was done elsewhere and the patient presented with a discharging sinus. You can see on the X-ray, the medial proximal tibial physis is open. So since the child is nearer to the skeletal maturity, there is an ongoing active infection, sequestrum is there, limb length discrepancy is expected. So because of this progressive deformity, medial physis was open and patient wasn't near skeletal maturity. So in this case, plan was a staged surgery, in which first stage I planned for debridement and drill epiphysiodesis of the remaining physis. And in second stage, we planned for gradual correction and lengthening with Elizaro ring fixator. So in first stage, debridement was done and drill epiphysiodesis was done. And this was at follow-up when patient presented with valgus and recurvatum at the proximal tibia, where everything was healed. And at this age, I planned for corrective osteotomy with gradual correction and lengthening through Elizaro. Since it was a biplanar deformity, so a biplanar planning was done and hinge was kept at the cora level and osteotomy was done. And this was at the correction. You can see the regenerate has formed very nicely and the length is being corrected. And this was after X-fix removal. So having said that, this is the protocol, this is the everything. So a 4-year-old boy with this deformity, what is the actual choice? Yes, we should wait, but still these type of procedure being done elsewhere. So in nutshell, whether to wait and when to intervene, we can follow this protocol. Firstly, we should identify the cause, whether it is an idiopathic physiological, whether it is metabolic, or whether it is progressive like skeletal dysplasia, post-infection, post-trauma. In case of idiopathic, if the mechanical axis is passing through zone 1, 2, the age is less than 10, we should wait. If its age is more than 10 and it's a girl, then we can go for a growth modulation. It's a boy, then can wait up to 12 and then plan for growth modulation. In case of idiopathic ones, when mechanical axis is passing through zone 3 and beyond, an option of an early age growth modulation can be given. In case of metabolic, first correct the metabolic profile and then treat them as idiopathic. In case of skeletal dysplasia, post-infection, post-trauma, since they are progressive and the growth potential on the side, affected side is also less, especially in case of bars and all things. So in those cases, we should plan the correction early so that we can get a decent correction up till the age of skeletal maturity. So elbow physis, if the elbow physis is near fusion, then I tend to wait and plan for one-time corrective osteotomy. Thanks.
Thank you so much. So that's an excellent talk. Sir, the concept of that arthrogram in distal femur you explained to us. Will you please explain again us how that work and how to look for everything?
What happens in case of skeletal dysplasia? It is very difficult to visualize the joint lines, whether you have to do that growth modulation on the femoral side or on the tibial side, because you are not able to make that joint line perfectly in the pre-operative X-ray. So what I do is I instill the dye, and we use that cautery thing or a parallel rod, straight rod, to see the alignment. And you can take the pictures on that intra Shyam image and just calculate the angle, so that you should be sure at what level the deformity is, so that you are not doing any harm by doing a joint line obliquity with the correction at that level where it is not needed. Like if we do femoral correction on the tibial side, then it can cause, or a tibial correction on the femoral side, then it can cause.
So after injecting the arthrogram, sir, you decide the joint line first on the both
See,
side, or
after injecting dye,
Yes, sir.
what I take is I use a parallel rod,
yes, sir.
and by keeping a K wire over that formed joint line, now you can visualize perfectly. And that straight rod, one is at the center of the hip and one is the center of the
Angle.
knee. And at that point, you can calculate the angle.
Okay.
Somebody else can calculate who is not washed, okay. On the CM. And
Okay.
with that, you can decide. Plus, the architecture of that tibial condyles also you can eyeball with that. Yes, the deformity is not there on the tibial side.
So basically, sir, this arthrogram will show you how the physis is oriented, right?
Yes.
So, okay, sure. Thank you, sir. I'll ask Dr. Godha to share her screen.
Yes.
So till Dr. Godha is sharing her screen, I would like to ask a few questions with Dr. Deepak.
So Deepak sir has to stop sharing for me to share the screen.
Yeah, so one is that Dr. Deepak, have you ever experienced failure of growth modulation in, I mean, girls, like when you have done growth modulation at around 10, 11, but the child is little obese?
Yeah, yeah.
Is obese.
See, I have a case. I have one case, and that was very close relative of mine, and we were very sure that yes, since she was not even menarche was not there, so even we didn't get an elbow X-ray in that case. But in the follow-up, I can see still there is no correction, there is no screw divergence, and there is a possibility of some hormonal imbalance in these cases. So it's better to get, especially in obese, dark, with that acanthosis nigrans sort of picture on the neck. So later on, we did that proper endo reference. So it came out to be some hormonal issues, because of which she's suddenly stopped growing. And menarche is also not there, first of all. Second thing is, in case of hypothyroidism, there is an instance when even at age of 15, post-menarche, 1 or 2 years, you still can see the elbow physis is open and femoral physis is open, and you can get a correction with growth modulation, especially in hypothyroid kids. So both the ways there is some discrepancy in it.
So another question is, have you seen this variation in elbow physis fusion or remaining physis growth and menarche, like one has been attained, another is remaining, and if that is there, how do you decide?
See, it's especially it's not. I have not seen any discrepancy related to menarche and elbow X-ray. First of all, like in those kids in which there is 6 months post menarche, you generally see the physis almost fused, or you will be seeing a very little scar. So this discrepancy I have not seen. So in those cases, I explain them the possibility of getting correction through PETs, because it's a faster process. But still, you have to explain them there is a possibility that you will not get the full correction and you might need an osteotomy. And if you want to wait, you can wait now, and we can do the osteotomy after 12 months. So this is my experience and protocol in this.
One last question is, how do you manage tibia vara, especially in males coming at 11, 12, and what is your experience with growth modulation if you do that?
Tibia vara, 11, 12-year-old male patients, especially boys, they respond very well. I put the lateral side plate, and they respond very good with that. I have 2-3 cases of those also.
Okay.
But this was Valgum, so I didn't.
That they respond slow.
Yes, since femoral correction is faster, tibial correction is slower. So yes, you have to take that thing in mind and plan the deformity correction accordingly, because femur corrects 1 degree per year sort of thing, and tibia corrects around 0.4 or 5 degrees per year.
Thank you.
Yes, Dr. Godha, you can share yours.
Yes, sir. So good morning, everyone. Today I'm going to present an interesting Genu Valgum case. We had a 7-year-old boy who presented with complaints of short left lower limb and deformity of the limb. On examination, there was limb length discrepancy of about 8.5 centimeters, and it was arising from the femoral component. And he had Genu Valgum. Clinically also, it was around 20 degrees of Genu Valgum. So we went, here we can see on the clinical examination that there was a scar on the medial aspect of the knee. Most probably it must have been some arthrotomy. He must have had some septic arthritis and underwent some arthrotomy. There was scar only on the medial aspect. And his radiographs revealed that he had about 20 degrees of Genu Valgum. The LDFA was around 69. We can see that the femur is very short, and the most significant thing in this is that the condyle, the lateral condyle of the femur, is absent. So we retrospectively went through his old X-rays, and here we can see that these are his radiographs and MRI few years back when he had some septic sequelae. So here we can see that there is some septa in that knee, and when we go back and see that there was a scar on the medial aspect, so most probably only the medial aspect of the joint was drained, and because of the septa, the lateral aspect wasn't drained properly, and hence that was the reason for the absence of the condyle. So because of that, he had a significant Genu Valgum as well as shortening. So with this picture, how do we manage this case? Can anyone?
See, at present, what
Yes,
is the condyle is deficient. Yes, you have pointed out very nicely. They have some plicas and septas in the joint, and because of those, there can be a unilateral affection also. But yes,
sir.
in your case, maybe it could be bilateral, and one side was drained and other was not drained. So that is seeing the X-ray. Can you go back to the X-ray?
Yes, sir.
X-ray. Yeah. So this is the presentation. So first of all, we should see what is the status of the condyle and what is the status of instability, whether it's unstable medial lateral, because it is a possibility there is some cartilaginous condyle which is not ossified or some sort of like that, like it happens in case of Blount's. Because yes, there is the condyle on the tibial side, but because of that pressure effect, it is not ossifying. So as soon as you relieve that pressure, it ossifies. So I will get an MRI at present in this case to see what is the status of that cartilaginous condyle and then plan further.
Okay, sir. What we have done is, in this case, we thought of first correcting the deformity, lengthening it, and since there's absence of condyle, we would definitely expect some amount of valgus again going on, as well as limb length discrepancy. So what we thought is we would proceed in a stage-wise manner. The patient's family was not intellectually good. So they wanted correction of the deformity and some lengthening. So in stage 1, we planned correction of the deformity along with some lengthening, and whatever residual valgus, which would definitely occur later on, and the residual limb length discrepancy would be managed in other stages. So what we did is we've done a common peroneal nerve release, and we've done a corrective osteotomy after calculating the cura. And then we've gone for a knee spanning Elizarov external fixator. So here the LDFA was around 67. So we did not go for a hinged correction in this case. We went for an acute correction followed by lengthening. So this is a paper which supports that we can do about 30 degrees of acute correction in children and then go for lengthening. So we did not go for a hinged correction because it was about 20 degrees, 23 degrees of deformity. So we acutely corrected it and started the post-op distraction on day 7 to let the periosteum heal. So this is post-acute correction, and that's the corticotomy site. And then we can see that the child is quite comfortable with the fixator on. And on the post-op day 7, we started distraction. And it was around 0.25 mm thrice a day. We did not go very fast, like 1 mm a day, because we have done an acute correction. And after the corticotomy site opened up, we went for 1 mm per day. And these are his sequential radiographs. We achieved around 5.8 centimeters of lengthening. And at that point, patient complained of pain. And hence we were worried about the knee dislocation or hip issues later on. We stopped the distraction and we explained to the patient that we will remove the fixator after it is consolidated well, and then go for staged surgeries later on when we find to correct the residual lengthening deficiency as well as any deformity which would occur later. So these are his clinical pictures post
You can
correction.
see, I'm just interrupting. You can see that the lateral condyle is now appearing. It is
Yes,
ossified
sir.
now. As soon as you decompress that thing, as it happens in Browns, so it can happen.
Yes, sir.
My motive was to see that whether there is some cartilaginous condyle, range is good. So yes, there will be some sort of enlarge there which can ossify. So
Yes.
I would have done, I don't do generally acute corrections if we are planning for Elizaro.
Yes.
I do a hinged correction and then convert that hinge into a straight rods, and those can be corrected very easily because it's more predictive, I think.
Yes, sir. Yes, sir.
Once you do an
I do agree.
and distracting it from the same side,
Yes,
the
sir.
quality of regenerate can be poor and it can lead to further prolongation of keeping that fixator, and it's very difficult to keep these fixator in these kids, first of all. Second, the incidence of dislocation, especially, it's not that high, especially in non-congenital cases. It is high in congenital cases like CFD, fibular hemilia, and all those things. But post-infective cases, now the soft tissue is not that hard, or it's a bit pliable. So they tend to take that thing and they don't dislocate generally, especially non-congenital causes are when they are non-congenital causes.
Yes, sir. So we would address the other issues later on. So this was our case. Thank you.
Thank you, sir.
One more thing we could have added is like when you have got certain degree of correction, now you can change that articulation or remove that tibial ring and start the mobilization of knee.
Yes, sir. Yes, sir. We actually planned to do that because there was some condyle loss and the child was complaining of significant knee pain. We thought we'll wait till it consolidates a little and then start the knee RO.
Okay, sure. Thank you, Goda. Sir, we are having only one case today because other case, sir, he's in conference right now. So thank you for the presentation, Goda, and thank you, Deepak sir,
Thank
for
you,
the
sir.
presentation.
Thank you.
Gaurav sir had put something that for Goda that was there a physeal bar in MRI finding?
Sir, that MRI was his childhood MRI. We did not get another.
Okay, thank you. Thank you, Deepak sir, for this nice presentation and giving us some new insight into the Genu Valgum cases. So next Saturday we will meet with Dr. P.N. Gupta and talk about the Genu Valgum. Yes, sir, Gaurav sir, yes.
Yeah, one point which I want to make is that as we see that there is complete absence of the lateral condyle, there's no ossification. So that sometimes happens in sequelae of septic knee arthritis because of the thrombosis of lateral femoral genicular artery.
Yes, sir, lateral genicular.
And so one tip is that we should always keep the knee in slight flexion whenever we are splinting it to avoid stretching of the vessels posteriorly when we are managing them acutely.
That will go into recurvatum, I think, if that artery gets.
Initially, when we put a slab in complete extension, that can stretch those vessels more and can cause more thrombosis.
Okay, sure. Thank you, sir. So thank you, everyone. Thank you, Deepak sir, Gaurav sir.
Thank you.
Thank you.